All right, welcome everyone. This is a super high yield review of thoracic outlet syndrome, and it's perfect for when you're gearing up for those anesthesia finals. Okay, let's just jump right in.
So, let's kick things off with a question for you. This is a total classic for exams. Now, if you're kind of scratching your head right now, don't even worry about it. Seriously, by the time we're done here, you'll be listing these off in your sleep. So, here's our game plan. We're going to cover what it is, the anatomy, the different syndromes, how it's treated, and then the big one for us, the key anesthetic considerations.
Okay, Section 1, the foundation. What is thoracic outlet syndrome? Let's start at the very beginning and make sure we're all on the same page.
So what is it really? In a nutshell, thoracic outlet syndrome, or TOS, is just a group of symptoms, and they're all caused by one thing: compression. You've got this bundle of nerves, an artery, and a vein, the neurovascular bundle, and it's getting squeezed as it tries to pass between the first rib and the collarbone. And here's the kicker: what gets squeezed determines the symptoms. It's that simple.
All right, next up, the blueprint. Let's look at the anatomy and what causes this whole mess. Now that we know what it is, let's dig into the why.
Okay, have a look at this. It really shows you just how well packed this area is. It's like a tiny crowded highway. You've got the brachial plexus, the subclavian artery, and the vein all trying to squeeze through this little gap between the collarbone and the first rib. This setup is the whole reason the syndrome exists. It's basically an anatomical bottleneck, you know? It's just primed for something to go wrong.
So what actually causes the squeeze? Well, it can be a whole bunch of things, but they fall into two big buckets. First, you've got congenital causes, stuff you're born with. Think an extra rib, called a cervical rib, or maybe some weird fibrous bands that shouldn't be there. Then you have the acquired causes. These are things that happen later. A classic one is a collarbone fracture that heals with a big lump of bone, a callus taking up space. Or you might see it in athletes who have really built up hypertrophic muscle.
So who are we most likely to see this in? Well, the data is pretty clear. It overwhelmingly affects young women, usually between 20 and 40 years old. I mean, look at that ratio. It's about 4 women for every 1 man. That's a huge difference. But here's a key point. If the cause is trauma, like a car accident, then that gender split disappears. It's 50-50.
Okay, moving on. The presentation, syndromes, and symptoms. So how does this actually show up in a patient? We're going to break it down into the 3 main clinical syndromes. And remember, it all depends on what's getting squished.
First up, and this is the big one, is neurogenic TOS. This guy accounts for over 90% of all cases, so it's the one you're going to see most often. And, like the name says, it's all about compression of the nerves, specifically the brachial plexus.
Okay, for your exam, you really need to know these symptoms. It's all about the lower nerve roots, C8 and T1. So what does that look like? Patients will complain of pain and that pins and needles feeling, paresthesia, but specifically in the ulnar nerve distribution. So think the pinky and ring finger. You might even see some wasting of the small muscles in the hand. That pattern is your moneymaker. It's a massive clue that points you away from other nerve issues. All right, next we've got arterial TOS. No surprise here, this is when the subclavian artery is getting compressed. This is kind of the athlete's version. You see it a lot in people who do repetitive overhead stuff. Swimmers, baseball pitchers, even painters.
The symptoms are exactly what you'd expect with poor blood flow. The arm will be pale, cold to the touch, and it'll hurt with use. That's claudication. But, and this is a huge but for your exam, the real danger is something called a post-stenotic aneurysm. Basically, the artery wall just past the tight spot gets weak and balloons out. This is a perfect spot for a clot to form, and if that clot breaks off and travels down the arm, well, that's a massive problem.
And boom, here's a perfect picture of exactly what I'm talking about. This is an arteriogram. You can literally see the point where the artery is getting squeezed. And then right after it, there it is, that dangerous ballooning. That's the aneurysm.
And last but not least, we have venous TOS. And I think you know where this is going. This is all about the subclavian vein getting compressed.
The best way to think about this one is a plumbing backup. Seriously, the blood just can't get out of the arm. So what do you see? Swelling, congestion. The arm might look bluish, cyanotic. And you'll often see these big popping veins across the chest and shoulder. If this whole situation leads to an acute clot, it gets its own fancy name, Paget-Schroeder syndrome. You might also hear it called effort thrombosis.
And this image, wow,
This is a venogram, and it shows that blockage perfectly. You can see the dye flowing down the vein, and then it just hits a wall, stops completely. That sharp line where it stops, that's called the meniscus sign, and it tells you you're dealing with a complete thrombosis. This is a big deal.
Okay, section 4. The fix. How do we actually diagnose and treat this? The game plan really depends on the type and how bad it is. It could be anything from physical therapy all the way to some pretty complex surgery. Let's talk about that acute venous clot we just saw. There's a pretty set protocol for that. Step 1, thrombolysis. You gotta bust up that clot with drugs. Step 2, anticoagulation. Start blood thinners to make sure it doesn't happen again. Step 3 is the big one, surgical decompression. Usually this means taking out the first rib to give everything more room. And finally, sometimes they'll do a balloon venoplasty afterwards, just to stretch the vein open and make sure it stays that way.
And this is what it's all about. This is the payoff. On the left, you've got that total blockage we saw before. And on the right, look at that. The vein is wide open, blood is flowing through. That is a fantastic result.
Okay, deep breath. This is the most important part for us, the plan, key anesthetic considerations. This is your bread and butter for the exam. What is our role when this patient comes to the OR? Getting this right is where you're going to rack up the points.
Think of this as your intra-op checklist, non-negotiable stuff. First, large bore IV access. And I mean large bore. You are working millimeters away from massive vessels. The risk of a major bleed is no joke. The risk of an air embolus is also very, very real. Next, positioning has to be perfect. And a big one, talk to your surgeon. If they're planning on using a nerve stimulator to find the brachial plexus, then you absolutely cannot use muscle relaxants.
Okay, now listen very carefully because this is a classic post-op trap. Do not, I repeat, do not get a false sense of security from a drain that isn't putting out much blood. Why? Because during a first rib resection, the pleura, the lining of the lung, often gets opened. So where's the blood going? It's not going into your drain. It's accumulating in the chest. They could be having a massive bleed, and you would have no idea just by looking at the drain.
So that brings us to this final critical question. You're in the recovery room, you know there's a risk of this hidden bleeding. What is the single most important thing you do? You get a chest x-ray, an erect chest x-ray. It's the only way you're going to know for sure if they have a hemothorax, blood in the chest, or a pneumothorax.
And that's a wrap. This whole explainer was based on an article from Anesthesia Tutorial of the Week on Thoracic Outlet Syndrome. Hopefully that was helpful. Now go ace those exams. Good luck.